Question 1. A 45-year-old male presents to the emergency department with sudden onset of severe chest pain radiating to his left arm, sweating, and shortness of breath. He has a history of hypertension and smoking. An excrescent segment elevation in the Roman Romnindef. What is the most appropriate initial management for this patient? A. Administer sublingual nitrates and aspirin, then refer for coronary angiography. B. Administer morphine, oxygen, nitrates, and aspirin and initiate thrombolytic therapy. C. Immediate coronary artery bypass grafting CAB. D. Administer antibiotics and observe for 24 hours. Answer. B. Administer morphine, oxygen, nitrates, and aspirin and initiate thrombolytic therapy. Explanation. This patient is presenting with signs and symptoms suggestive of acute myocardial infarction, specifically in St. segment elevation, STEMI, indicated by the St. segment elevation in the Roman Romnindef. Immediate management for STEMI involves administering morphine for pain relief, oxygen if saturation is low, nitrates to reduce myocardial oxygen demand, and aspirin to inhibit platelet aggregation. Thrombolytic therapy, G. All supplies should be initiated at ECA. Percutaneous coronary intervention is not available or cannot be performed within a timely manner. Earlier perfusion is crucial to minimize myocardial damage. CABG is generally not the first-line treatment in the acute setting of STEMI unless there are complications like left main stem disease or multivessel involvement that cannot be managed by ECI. Antibiotics are not indicated in this case. Question 2. Mr. Thomas, a 56-year-old male with a history of type 2 diabetes and obesity, presents with fatigue, polyuria, and excessive thirst. On examination, he is found to have a blood glucose level of 18 ml. His HbAC is 9.2%. What is the most appropriate next step in the management of his condition? A. Start insulin therapy and arrange for a follow-up in 6 months. B. Start metformin and initiate lifestyle modifications. C. Start glucagon-like peptide on GLP-1 receptor agonist and advise immediate hospitalization. D. Initiate immediate insulin therapy and refer to a diabetes education program. Answer. B. Start metformin and initiate lifestyle modifications. Explanation. Mr. Thomas's symptoms and laboratory findings suggest poorly controlled type 2 diabetes. The initial treatment approach for type 2 diabetes typically involves lifestyle modifications, dietary changes, exercise, and weight management, alongside metformin, which is the first-line oral agent for managing type 2 diabetes. His blood glucose 18 ml and HbAC 9.2% are elevated, indicating inadequate glycemic control, but the decision to start insulin therapy is generally reserved for cases where oral medications are ineffective or in patients with severe hyperglycemia. Insulin therapy is usually introduced after the failure of oral agents, and a referral to a diabetes education program would be appropriate. But the first step would be metformin and lifestyle changes. GLP-1 receptor agonists are considered in patients who fail oral agents or in those with obesity and poor control. Question 3, scenario question. Mr. Harris, a 70-year-old male, has a long-standing history of rheumatoid arthritis and is experiencing a flare-up of joint pain, particularly in the knees and hands. He is currently on methotrexate for disease-modifying treatment, but his symptoms have worsened recently and he is presenting with a fever, fatigue, and a general feeling of being unwell. His CRP, C-reactive protein, is significantly elevated. What is the most likely cause of his symptoms and what should be the next step in management? A. Infective arthritis due to methotrexate-induced immunosuppression. Initiate broad-spectrum antibiotics. B. A flare-up of rheumatoid arthritis. Increase the methotrexate dose and monitor for side effects. C. Acute gouty arthritis. Initiate NSAIDs and colchicine therapy. D. Sepsis from a concomitant infection unrelated to rheumatoid arthritis. Initiate fluid resuscitation and broad-spectrum antibiotics. Answer. A. Infective arthritis due to methotrexate-induced immunosuppression. Initiate broad-spectrum antibiotics. Explanation. Given Mr. Harris's presentation with fever, elevated CRP, and a long-standing history of rheumatoid arthritis, RA, the most likely cause of his symptoms is infective arthritis, which can occur in patients on immunosuppressive medications such as methotrexate. Methotrexate, while effective for routing susceptibility to infections, including bacterial arthritis, due to its immunosuppressive effects. The next step in management would be to initiate broad-spectrum antibiotics to cover potential bacterial infections, particularly gram-positive organisms such as Staphylococcus aureus. A flare-up of RA typically would not present with fever or elevated TRP to this extent, and increasing the methotrexate dose is not appropriate in this context. Gout would typically present with acute pain and swelling in one joint, often the big toe, and sepsis is unlikely without. A clear source of infection such as a wound or urinary tract infection. Question 4. A 32-year-old female presents with a persistent cough, fever, and weight loss for the past few weeks. She has a history of contact with a family member who was recently diagnosed with tuberculosis. A chest X-ray shows upper lobe consolidation with cavitation. What is the most appropriate next step in the management of this patient? A. Start broad-spectrum antibiotics and discharge the patient. B. Order a sputum smear and culture for Mycobacterium tuberculosis. Initiate contact tracing. C. Initiate antiviral therapy for suspected viral pneumonia. D. Begin treatment for bacterial pneumonia with antibiotics and monitor for 48 hours. Answer. B. Order a sputum smear and culture for Mycobacterium tuberculosis. Initiate contact tracing. Explanation. This patient's clinical presentation with persistent cough, fever, weight loss, and history of exposure to person with tuberculosis (TB) is highly suggestive of active tuberculosis. The next step should be to confirm the diagnosis by obtaining sputum samples for smear microscopy and culture to detect Mycobacterium tuberculosis. Given the infectious nature of TB, contact tracing is crucial to identify and assess individuals who may have been exposed to the patient. Broad-spectrum antibiotics are inappropriate here because the patient may have TB, not bacterial pneumonia. Antiviral therapy is not indicated unless viral pneumonia is suspected, and bacterial pneumonia typically does not present with cavitary lesions seen on chest X-ray. Question 5. A 62-year-old male with a history of hypertension and diabetes presents to the emergency department with a sudden onset of right-sided weakness and slurred speech. He is unable to raise his right arm and has difficulty speaking. His blood pressure is 180/100 Hg, and his Glasgow Coma Scale score is 14. AK of the head shows no acute intracranial hemorrhage. What is the most appropriate next step in management? A. Initiate thrombolytic therapy for acute ischemic stroke. B. Administer antihypertensive medication to lower the blood pressure. C. Initiate anticoagulants for suspected cardioembolic stroke. D. Perform a lumbar puncture to rule out infection. Answer A. Initiate thrombolytic therapy for acute ischemic stroke. Explanation. This patient's presentation with sudden onset right-sided weakness, slurred speech, and risk factors for stroke, hypertension, and diabetes strongly suggests an acute ischemic stroke. CT scan showing no acute hemorrhage confirms the likelihood of ischemic stroke. The most appropriate next step is to administer thrombolytic therapy, e.g. alteplase, within 4.5 hour window from symptom onset to help dissolve the clot causing the ischemia and restore blood flow to the affected area. Blood pressure management is important, but lowering it aggressively in the acute phase of stroke can worsen ischemia. Anticoagulants are generally not used in acute ischemic stroke unless there is clear cardioembolic source. Lumbar puncture is not indicated in the evaluation of acute ischemic stroke unless there is suspicion of infection or subarachnoid hemorrhage, neither of which is suggested by the current clinical presentation. Question 6. A 45-year-old female with a history of systemic lupus erythematosus, sleep presents with a new onset rash across her cheeks and nose, sparing the nasolabial folds. She also reports joint pain and recent fatigue. Laboratory studies reveal positive nuclear antibodies on her and anti-DNA antibodies. What is the most likely diagnosis and what is the next step in management? A. Rheumatoid arthritis with systemic involvement. Initiate methotrexate therapy. B. Systemic lupus erythematosus flare-up. Increase immunosuppressive therapy and manage symptoms. C. Psoriasis with systemic involvement. Start topical corticosteroids and vitamin D analogues. D. Acute viral infection causing a rash and joint symptoms. Observe and provide symptomatic treatment. Answer B. Systemic lupus erythematosus flare-up. Increase immunosuppressive therapy and manage symptoms. Explanation. The patient's clinical presentation, including butterfly-shaped rash across her cheeks and nose, along with fatigue, joint pain, and laboratory findings of positive UNA and DNA antibodies, is highly suggestive of flare-up of systemic lupus erythematosus. Sleep. This autoimmune disorder can affect multiple organ systems, including the skin and joints. The most appropriate step is to increase immunosuppressive therapy, such as corticosteroids or hydroxychloroquine, and manage her symptoms. Methotrexate is typically used for diseases like rheumatoid arthritis but is not first line for SLE. Psoriasis typically presents with well-defined plaques and is not associated with the characteristic butterfly-shaped rash seen in SLE. Acute viral infections causing similar symptoms would not explain the positive anion antibodies. Question 7. Scenario question. Mr. Graham, a 58-year-old male, presents with complaints of sudden onset severe abdominal pain that started in the epigastric region and radiated to his back. He has a history of alcohol use and gallstones. On examination, he is tachycardic, hypotensive, and has a distended abdomen. His serum amylase and lipase levels are markedly elevated. What is the most likely diagnosis and what is the next step in management? A. Acute pancreatitis due to gallstones. Initiate intravenous fluids, withhold oral intake, and consider antibiotics if there is evidence of infection. B. Peptic ulcer perforation. Initiate surgical consultation and start intravenous proton pump inhibitors. C. Acute myocardial infarction. Administer aspirin and consider thrombolytic therapy. D. Bowel obstruction. Initiate nasogastric tube insertion and observe. Answer A. Acute pancreatitis due to gallstones. Initiate intravenous fluids, withhold oral intake, and consider antibiotics if there is evidence of infection. Explanation. This patient's clinical presentation of sudden onset severe epigastric pain radiating to the back combined with his history of alcohol use and gallstones strongly suggests acute pancreatitis. Elevated amylase and lipase levels are typical markers of pancreatitis. The initial management includes intravenous fluids to support hemodynamics, withholding oral intake to rest the pancreas, and monitoring for complications such as infection, for which antibiotics might be considered. Gallstones are a common cause of acute pancreatitis, and if the pancreatitis is severe or complicated by infection, further interventions, imaging to assess for cholecystitis or bile duct obstruction, may be needed. Peptic ulcer perforation presents with different characteristics, e.g. sudden severe abdominal pain, but without elevated amylase lipase levels, and would require surgical consultation. Myocardial infarction can present with abdominal pain, but is unlikely to cause marked elevations in pancreatic enzymes. Bowel obstruction does not typically present with elevated amylase and lipase. Question 8. A 24-year-old female presents with fever, malaise, and a painful, swollen right knee. She reports having had a sore throat 2 weeks ago. On examination, she has a fever of 38.2 and her right knee is erythematous, swollen, and tender. A throat culture obtained 2 weeks ago was positive for group streptococcus. What is the most likely diagnosis and what is the appropriate treatment? A. Septic arthritis caused by streptococcus. Initiate joint aspiration and broad-spectrum antibiotics. B. Acute rheumatic fever with migratory arthritis. Initiate aspirin and corticosteroids. C. Gonococcal arthritis. Start ceftriaxone and azithromycin. D. Lyme disease arthritis. Begin doxycycline and arrange for follow-up appointment. Answer. B. Acute rheumatic fever with migratory arthritis. Initiate aspirin and corticosteroids. Explanation. This patient's presentation of fever, migratory arthritis, and recent history of streptococcal throat infection is highly suggestive of acute rheumatic fever (ARF), which can result in migratory arthritis as one of its manifestations. ARF is systemic inflammatory disease that occurs as complication of an untreated or inadequately treated group streptococcus throat infection. The appropriate treatment includes anti-inflammatory medications, such as aspirin or corticosteroids, to manage the inflammatory response. Septic arthritis caused by streptococcus would present with more localized joint infection, and joint aspiration would be necessary, but the history of recent streptococcus throat infection makes ARF more likely in this case. Gonococcal arthritis typically presents with polyarthritis and mucocutaneous lesions and is unlikely given the absence of sexual history. Lyme disease typically involves tick exposure history, and the patient's presentation does not fit that pattern. Question 9. A 55-year-old male with a history of chronic obstructive pulmonary disease, COPD, presents with increasing shortness of breath, productive cough with green sputum, and a fever. His oxygen saturation is 89% on room air. His chest X-ray shows hyperinflation, and there are no signs of consolidation. What is the most likely cause of his symptoms, and what is the next step in management? A. Acute exacerbation of COPD. Initiate nebulized bronchodilators, corticosteroids, and antibiotics. B. Community-acquired pneumonia. Start empirical antibiotic therapy. C. Acute asthma exacerbation. Initiate high-dose inhaled corticosteroids and beta agonists. D. Pulmonary embolism. Initiate anticoagulation therapy. Answer A. Acute exacerbation of COPD. Initiate nebulized bronchodilators, corticosteroids, and antibiotics. Explanation: this patient's presentation with increased shortness of breath, productive cough, and fever in the setting of chronic obstructive pulmonary disease (COPD) is most likely due to an acute exacerbation of COPD, ECOPD often triggered by infections, bacterial or viral. The management of ECOPD involves nebulized bronchodilator, relieve airway obstruction, corticosteroids to reduce inflammation, and antibiotics if there is evidence of bacterial infection such as the productive cough with green sputum. The chest X-ray showing hyperinflation supports the diagnosis of COPD, but no consolidation suggests that pneumonia is less likely. Community-acquired pneumonia would typically show signs of consolidation on chest imaging, making it less likely in this case, while an acute exacerbation might present similarly. The patient's history of COPD and the absence of other asthma-specific triggers make this diagnosis less likely. Pulmonary embolism typically presents with sudden onset of pleuritic chest pain, shortness of breath, and hypoxia, but would not be the primary consideration without these features and would require imaging such as CT pulmonary angiogram for diagnosis. Question 10. A 72-year-old female with a history of osteoporosis presents with acute back pain after bending over to pick up a heavy object. She has difficulty moving and reports significant pain in her mid-back. On examination, there is tenderness over her thoracic spine and her spinal range of motion is limited due to pain. A plain X-ray shows a vertebral compression fracture. What is the next step in management? A. Immediate surgical intervention to stabilize the fracture. B. Initiate bisphosphonate therapy to treat osteoporosis. C. Conservative management with pain control, rest, and physical therapy. D. Perform a bone scan to evaluate for metastatic disease. Answer C. Conservative management with pain control, rest, and physical therapy. Explanation: in the case of a vertebral compression fracture due to osteoporosis, the first-line treatment is typically conservative management, which includes pain control, e.g., NSAIDs or opioids, rest, and physical therapy to strengthen the surrounding muscles and improve mobility. Bisphosphonates or other medications to treat osteoporosis may be considered to prevent future fractures but are not immediately necessary for the management of the acute fracture. Surgical intervention is reserved for cases with neurological compromise, severe deformity, or persistent pain despite conservative measures. A bone scan is typically needed unless there is concern for a different underlying cause, such as metastatic disease, but this patient's history and presentation suggest osteoporosis-related compression fracture as the most likely diagnosis. Question 11. A 34-year-old female presents with a 3-month history of fatigue, weight loss, and a non-productive cough. She also reports night sweats and hemoptysis. On examination, she is febrile and has dullness to percussion over her right lower lung. A chest X-ray shows a right-sided consolidation with a pleural effusion. Her tuberculin skin test is positive. What is the most appropriate next step in her management? A. Start broad-spectrum antibiotics and await culture results. B. Initiate antituberculous treatment and arrange further tests. C. Perform a EK of the chest to evaluate for lung cancer. D. Refer for urgent thoracentesis to drain the pleural effusion. Answer B. Initiate antituberculous treatment and arrange further tests. Explanation: the patient's symptoms, fatigue, weight loss, non-productive cough, night sweats, and hemoptysis are highly suggestive of tuberculosis TB, and her positive tuberculin skin test (TSD) further supports this diagnosis. In suspected cases of active TB, it is important to initiate antituberculous treatment as soon as possible while microbiological confirmation from sputum cultures. This approach prevents further transmission of the disease. While broad-spectrum antibiotics may initially be considered for empirical treatment of pneumonia, the clinical presentation is more consistent with TB than a simple bacterial pneumonia. CT scan may be helpful in evaluating lung pathology, but is not the immediate next step in management. Thoracentesis is not indicated. There is concern for complicated pleural effusion, and even then, it is performed after initiating TB treatment. Question 12. A 55-year-old male presents with a 6-month history of increasing forgetfulness and difficulty performing activities of daily living. His family reports he has become more socially withdrawn and has had personality changes. On examination, he exhibits poor short-term memory, impaired attention, and difficulty recalling recent events. His MRI brain scan reveals hippocampal atrophy. What is the most likely diagnosis? A. Vascular dementia. B. Alzheimer's disease. C. Parkinson's disease with dementia. D. Frontotemporal dementia. Answer: B. Alzheimer's disease. Explanation: Alzheimer's disease is the most common cause of dementia, particularly in older adults. The patient's history of progressive cognitive decline, including memory impairment, personality changes, and social withdrawal in the context of MRI findings of hippocampal atrophy, is characteristic of Alzheimer's disease. The hippocampus plays a crucial role in memory, and its atrophy is a key feature of this condition. Dementia typically presents with more abrupt cognitive changes, often following stroke or with associated vascular risk factors. Parkinson's disease with dementia presents with both motor symptoms and cognitive decline, but the cognitive changes typically occur later in the disease course. Frontotemporal dementia often presents with early changes in behavior and personality, but not a significant memory impairment. Question 13. Mr. Williams, a 45-year-old man, presents with sudden onset right-sided weakness and slurred speech. His symptoms began 3 hours ago while he was at work. He has a history of hypertension and smoking. On examination, he is hypertensive with a right-sided hemoptysis and dysphagia. CT head shows no acute hemorrhage. What is the most appropriate initial management? A. Administer aspirin and monitor closely. B. Start intravenous tissue plasminogen activator (EPA) if within the time window. C. Perform a lumbar puncture to rule out subarachnoid hemorrhage. D. Begin anticoagulation therapy and transfer to a stroke unit. Answer: B. Start intravenous tissue plasminogen activator (EPA) if within the time window. Explanation: This patient presents with acute onset right-sided weakness and slurred speech, which are suggestive of an ischemic stroke. The most appropriate treatment in the early hours of an ischemic stroke, particularly within 4.5 hours of symptom onset, is intravenous tissue plasminogen activator (EPA), which can help dissolve the clot. Improve outcomes. The CT scan ruling out hemorrhage is essential, as EPA is contraindicated in the setting of an acute hemorrhagic stroke. Aspirin may be used after the acute phase of ischemic stroke, but is not effective in the acute setting to dissolve the clot. A lumbar puncture is not indicated unless there is suspicion of subarachnoid hemorrhage, which does not align with this patient's presentation. Anticoagulation therapy is not used acutely in ischemic stroke unless there is evidence of atrial fibrillation or other high-risk factors. Question 14. A 28-year-old woman presents with a 3-day history of severe right lower abdominal pain, nausea, and vomiting. She is sexually active and uses oral contraception. On examination, she has tenderness in the right lower quadrant with guarding and rebound tenderness. Urine pregnancy test is negative. A pelvic ultrasound shows a complex cyst on the right ovary. What is the most likely diagnosis? A. Ectopic pregnancy. B. Ovarian torsion. C. Pelvic inflammatory disease PID. D. Appendicitis. Answer: B. Ovarian torsion. Explanation: The patient's presentation with acute right lower quadrant pain, nausea, vomiting, and tenderness on examination, combined with the ultrasound findings of complex ovarian cyst, strongly suggests ovarian torsion. This occurs when an ovarian cyst or mass causes the ovary to twist on its vascular pedicle, leading to ischemia and pain. Ectopic pregnancy should be considered in sexually active women, but negative pregnancy test reduces its likelihood. Pelvic inflammatory disease, PID, typically presents with pelvic pain, fever, and vaginal discharge, which are not consistent with this case. Appendicitis can cause right lower quadrant pain, but the absence of fever, the presence of nausea and vomiting, and the ovarian cyst on ultrasound make ovarian torsion the most likely diagnosis. Question 15. A 67-year-old male with a history of type 2 diabetes and chronic kidney disease presents with new onset swelling in his legs, shortness of breath, and orthopnea. On examination, he has bilateral pitting edema and a displaced apex beat. An echocardiogram shows reduced ejection fraction and diastolic dysfunction. What is the most likely cause of his symptoms? A. Diabetic nephropathy. B. Acute myocardial infarction. C. Congestive heart failure. D. Pulmonary embolism. Answer: C. Congestive heart failure. Explanation: This patient's symptoms of leg swelling, shortness of breath, orthopnea, and physical examination findings of pitting edema and displaced apex beat are indicative of congestive heart failure (CHF). The reduced ejection fraction on the echocardiogram confirms the presence of systolic dysfunction, which is common in CHF. Chronic kidney disease (CKD) is known risk factor for the development. Heart failure. Diabetic nephropathy can lead to kidney failure, but it does not directly cause symptoms of heart failure. An acute myocardial infarction could cause similar symptoms, but would typically present with chest pain and elevated cardiac biomarkers. Pulmonary embolism would present more acutely with sudden onset shortness of breath and chest pain, which is not seen in this patient. Question 16. A 72-year-old woman presents with a 2-month history of fatigue, weight loss, and generalized weakness. She has a past medical history of rheumatoid arthritis for which she takes methotrexate. On examination, she appears pale and has a soft, non-tender spleen. Her blood count shows a hemoglobin level of 9 grams, still a white blood cell count of 3.5 x 100 nil, and platelet count of 150 x 100 nil. Her liver function tests are normal, but her reticulocyte count is low. What is the most likely diagnosis? A. Iron deficiency anemia. B. Methotrexate-induced bone marrow suppression. C. Myelodysplastic syndrome. D. Anemia of chronic disease. Answer: B. Methotrexate-induced bone marrow suppression. Explanation: this patient's symptoms, including fatigue, weight loss, and generalized weakness, along with her use of methotrexate, suggest possible adverse effect of the medication. Methotrexate can cause bone marrow suppression, leading to pancytopenia, low hemoglobin, low white blood cells, and normal platelets. In this case, low reticulocyte count suggests that the bone marrow is not adequate, compensating for the low hemoglobin level. Iron deficiency anemia typically presents with low reticulocyte count, but would not be associated with low white blood cell count and normal platelets in the absence of chronic blood loss. Myelodysplastic syndrome (MDS) is possible differential, but would typically present with more severe cytopenias and dysplastic cells on the peripheral blood smear. Anemia of chronic disease is unlikely in this case because her liver function tests are normal and there is evidence of chronic inflammatory process. Question 17. A 50-year-old woman presents with sudden onset chest pain radiating to her back. She describes the pain as tearing in nature. She has a history of hypertension and smoking. On examination, her blood pressure is 100 to 100 mmHg and she has a weak absent pulse in her left arm. A chest x-ray reveals a widened mediastinum. What is the most likely diagnosis? A. Acute coronary syndrome. B. Pulmonary embolism. C. Aortic dissection. D. Spontaneous pneumothorax. Answer: C. Aortic dissection. Explanation: the patient's sudden onset tearing chest pain radiating to the back along with hypertension and a widened mediastinum on chest x-ray is highly suggestive of an aortic dissection. Aortic dissection occurs when there is a tear in the intimal layer of the aorta, allowing blood to flow between the layers of the vessel, causing a separation of the layers dissection. This can lead to severe pain and compromise blood for the limbs as evidenced by the weak, absent pulse in her left arm. Acute coronary syndrome acts typically presents with central chest pain and does not cause a widened mediastinum or absent pulses. Pulmonary embolism usually presents with pleuritic chest pain and dyspnea, and spontaneous pneumothorax typically causes sharp pleuritic pain and does not explain the widened mediastinum or absent pulses. Question 18. A 35-year-old man presents with a 4-day history of painful, swollen joints in his knees, ankles, and wrists. He reports a recent episode of diarrhea. On examination, he has erythema and swelling in multiple joints, particularly the knees. He has no history of trauma or recent infections. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Reactive arthritis. D. Psoriatic arthritis. Answer: C. Reactive arthritis. Explanation: this patient's presentation with painful, swollen joints after recent episode of diarrhea is suggestive of reactive arthritis, condition that typically follows an infection, commonly gastrointestinal or genitourinary. Reactive arthritis can cause asymmetric oligoarticular arthritis, commonly affecting the lower extremities such as knees and ankles. The association with recent diarrhea support. Infection-related etiology. Rheumatoid arthritis generally affects the small joints symmetrically, and systemic lupus erythematosus presents with other systemic features such as butterfly rash. Psoriatic arthritis is associated with history of psoriasis and typically affects the distal joints and nails. Question 19. A 62-year-old male presents with progressively worsening exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea over the last 3 months. He has a history of hypertension and a 40-pack-year smoking history. On examination, he has bilateral ankle edema, elevated jugular venous pressure, and crackles in the lungs. An echocardiogram shows a reduced ejection fraction. What is the most likely cause of his symptoms? A. Chronic obstructive pulmonary disease, COPD. B. Heart failure with reduced ejection fraction, HFrEF. C. Pulmonary embolism. D. Acute myocardial infarction. Answer: B. Heart failure with reduced ejection fraction, HFrEF. Explanation: this patient presents with symptoms of congestive heart failure, including exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea in the setting of a reduced ejection fraction on echocardiogram. The presence of bilateral ankle edema, elevated jugular venous pressure, and crackles in the lungs further supports the diagnosis of heart failure with reduced ejection HFrEF. COPD typically presents with a history of chronic cough and sputum production, and while it can cause dyspnea, it does not cause elevated jugular venous pressure or pulmonary crackles. Pulmonary embolism typically presents with acute onset dyspnea and chest pain, while acute myocardial infarction would present with more acute symptoms and chest pain. Question 20. A 45-year-old male with a history of chronic alcohol use presents with confusion, ataxia, and nystagmus. His gait is unsteady, and he has difficulty standing with his eyes closed. He has a history of poor nutrition. What is the most likely diagnosis? A. Wernicke's encephalopathy. B. Acute alcoholic intoxication. C. Cerebellar stroke. D. Hypoglycemia. Answer: A. Wernicke's encephalopathy. Explanation: this patient's history of chronic alcohol use, confusion, ataxia, nystagmus, and difficulty standing with his eyes closed suggests Wernicke's encephalopathy. Wernicke's encephalopathy is caused by thiamine, vitamin B deficiency, often in the setting of chronic alcohol use and poor nutrition. The classic triad includes confusion, ataxia, and ophthalmoplegia, though not all symptoms need to be present. Acute alcoholic intoxication may cause confusion and ataxia, but it would be associated with more immediate history of alcohol consumption. Cerebellar stroke would cause more focal neurological deficits, and hypoglycemia would cause confusion but would typically be associated with history of fasting, insulin use, or recent strenuous activity. Question 21. A 25-year-old female presents with a 2-week history of a painless lump in her neck. She also reports intermittent low-grade fever and night sweats. Her past medical history is unremarkable, and she is not taking any medications. On examination, she has a firm, non-tender mobile lymph node in the left cervical region. The remainder of her examination is normal. What is the most likely diagnosis? A. Infectious mononucleosis. B. Hodgkin lymphoma. C. Non-Hodgkin lymphoma. D. Tuberculosis. Answer: B. Hodgkin lymphoma. Explanation: this patient's presentation with painless cervical lymphadenopathy, intermittent fever, and night sweats is most suggestive of Hodgkin lymphoma, type of cancer that typically presents with painless enlarged lymph nodes and constitutional symptoms such as fever and night sweats. The B symptoms: infectious mononucleosis could also present with lymphadenopathy, but it typically involves both cervical and other lymph node groups and often presents with sore throat and fatigue. Non-Hodgkin lymphoma usually presents with widespread, more aggressive lymphadenopathy, and tuberculosis typically causes more systemic symptoms such as weight loss and productive cough, especially in endemic areas. Question 22. A 65-year-old man with a history of type 2 diabetes, hypertension, and hyperlipidemia presents with a new onset of chest pain. The pain is substernal, radiating to his left arm, and occurs at rest. He is a smoker with a 40-pack-year history. On examination, his blood pressure is 159 Hg and his pulse is 98 beats per minute. The Ecchosan segment depression in leads VV6. What is the most likely diagnosis? A. Stable angina. B. Unstable angina. C. Acute myocardial infarction. D. Aortic dissection. Answer: B. Unstable angina. Explanation: this patient's presentation with new onset chest pain at rest, radiating to his left arm, along with segment depression on the Ec is highly suggestive of unstable angina. Unstable angina is a form of acute coronary syndrome ACS where there is insufficient blood flow to the heart muscle, but no complete occlusion of the coronary artery, hence no myocardial infarction. Stable angina typically occurs exertion and is relieved by rest. Acute myocardial infarction, MI, usually presents with more significant changes such as segment elevation or deep Q waves, and aortic dissection typically presents with tearing chest pain radiating to the back. Question 23. A 55-year-old female presents with joint pain in her hands, knees, and hips. She describes morning stiffness lasting for about 30 minutes, which improves as the day progresses. She also reports fatigue and recent weight loss. On examination, she has bilateral swelling and tenderness in the metacarpophalangeal and proximal interphalangeal joints. Her rheumatoid factor is positive. What is the most likely diagnosis? A. Osteoarthritis. B. Psoriatic arthritis. C. Rheumatoid arthritis. D. Systemic lupus erythematosus. Answer: C. Rheumatoid arthritis. Explanation: this patient's presentation of joint pain, morning stiffness, and positive rheumatoid factor is most consistent with rheumatoid arthritis. RA is an autoimmune condition that commonly affects the small joints of the hands, wrists, and feet. The morning stiffness that improves with activity and the presence of bilateral joint swelling are characteristic features of RA. Osteoarthritis typically presents with joint pain that worsens with activity, and it usually affects weight-bearing joints. Psoriatic arthritis is often associated with skin psoriasis and can affect both the small and large joints, but without the classic rheumatoid factor and symmetrical joint involvement. Systemic lupus erythematosus, SLE, often presents with malar rash and is typically associated with wide range of systemic manifestations, including renal involvement. Question 24. A 32-year-old female presents with a 2-month history of increased fatigue, weight gain, and cold intolerance. She also reports constipation, dry skin, and thinning hair. On examination, her pulse is 50 beats per minute and she has a hoarse voice. A thyroid function test shows of 12.0 mol and a Freed of 8.0 pmol. What is the most likely diagnosis? A. Hypothyroidism. B. Hypothyroidism. C. Hashimoto thyroiditis. D. Pituitary adenoma. Answer: B. Hypothyroidism. Explanation: this patient's symptoms of fatigue, weight gain, cold intolerance, constipation, dry skin, and thinning hair, along with the laboratory findings of an elevated TH and low free T, are consistent with primary hypothyroidism. In primary hypothyroidism, the thyroid gland does not produce enough thyroid hormone, leading to compensatory increase in TSH. Hashimoto thyroiditis is the most common cause of hypothyroidism and is an autoimmune disease where the immune system attacks the thyroid gland, leading to its dysfunction. Hypothyroidism would present with symptoms of weight loss, heat intolerance, and tachycardia, and pituitary adenoma typically causes symptoms related to pituitary hormone excess or visual disturbances. Question 25. A 40-year-old man presents with a 1-week history of fever, sore throat, and painful swallowing. He reports a recent history of unprotected sexual intercourse. On examination, he has erythematous pharynx with exudates and tender cervical lymphadenopathy. His rapid antigen test for group if Streptococcus is negative. What is the most likely diagnosis? A. Infectious mononucleosis. B. Streptococcal pharyngitis. C. Herpes simplex virus, CTSV pharyngitis. D. Gonococcal pharyngitis. Answer: A. Infectious mononucleosis. Explanation: this patient's sore throat, fever, and tender cervical lymphadenopathy, along with negative rapid antigen test for group Streptococcus, suggest infectious mononucleosis, which is commonly caused by Epstein-Barr virus (EBV). The patient's recent history of unprotected sexual intercourse and the presence of exudates on the pharynx are also consistent with streptococcal pharyngitis. Typically presents with fever and exudates, but would be positive on the rapid antigen test for group Streptococcus. Herpes simplex virus (HSV) pharyngitis usually causes painful ulcers, and gonococcal pharyngitis typically presents with purulent discharge and is associated with gonococcal infection. Question 26. A 75-year-old man with a history of chronic obstructive pulmonary disease (COPD) presents with increased shortness of breath, cough, and purulent sputum. His symptoms have worsened over the past 3 days. On examination, he is tachypneic, using accessory muscles for breathing, and has decreased breath sounds and wheezing. What is the most likely diagnosis? A. Acute asthma exacerbation. B. Acute exacerbation of chronic obstructive pulmonary disease (COPD). C. Pulmonary embolism. D. Community-acquired pneumonia. Answer: B. Acute exacerbation of chronic obstructive pulmonary disease (COPD). Explanation: This patient's history of COPD and presentation with increased shortness of breath, purulent sputum, tachypnea, and use of accessory muscles is most consistent with an acute exacerbation of COPD. Acute exacerbations of COPD are often triggered by infections or environmental factors and present with worsening respiratory symptoms. In contrast, acute exacerbation is more likely in a patient with a history of asthma and pulmonary embolism, usually presents with sudden onset pleuritic chest pain and dyspnea. Community-acquired pneumonia may cause similar symptoms, but typically presents with fever and crackles on auscultation, along with signs of infection. Question 27. A 45-year-old female with a history of breast cancer treated with surgery, chemotherapy, and radiation presents with new onset back pain. The pain is constant, worse at night, and not relieved by rest. She also reports unintentional weight loss and fatigue. What is the most likely diagnosis? A. Osteoarthritis. B. Spinal metastases. C. Mechanical back pain. D. Acute disc herniation. Answer: B. Spinal metastases. Explanation: this patient's history of breast cancer and new onset back pain, along with weight loss and fatigue, raises concern for spinal metastases. Metastatic breast cancer frequently spreads to the bones, particularly the spine, and can present with back pain that is worse at night and not relieved by rest. Osteoarthritis typically causes pain that worsens with activity and improves with rest, and mechanical back pain often results from musculoskeletal strain. Acute disc herniation typically causes radicular pain and may be associated with neurological deficits, but does not commonly present with systemic symptoms like weight loss. Question 28. A 32-year-old male presents with a 2-week history of painful swelling of his right knee, along with redness and warmth. He has a history of intravenous drug use. On examination, his right knee is erythematous, swollen, and tender to touch with limited range of motion. Aspiration of the knee joint yields a purulent fluid. What is the most likely causative organism? A. Staphylococcus aureus. B. Streptococcus pneumoniae. C. Neisseria gonorrhoeae. D. Mycobacterium tuberculosis. Answer: A. Staphylococcus aureus. Explanation: the patient's presentation of painful, swollen, and erythematous knee joint with purulent fluid obtained on aspiration is most consistent with septic arthritis in an adult with a history of intravenous drug use. The most common causative organism is Staphylococcus aureus, including methicillin-resistant strains (MRA). Streptococcus pneumoniae can also cause septic arthritis, but is less common than Staphylococcus aureus in adults. Neisseria gonorrhoeae typically causes septic arthritis in sexually active individuals, but it is less common in patients with intravenous drug use. Mycobacterium tuberculosis can cause septic arthritis, but this typically occurs in patients with immunosuppression or chronic conditions. Question 29. A 68-year-old woman with a history of diabetes presents with blurred vision, difficulty reading, and a decrease in visual acuity over the past few months. She has no pain or redness. On examination, her blood pressure is 150/90 Fovomet G, and fundoscopy reveals cotton wool spots, microaneurysms, and hard exudates. What is the most likely diagnosis? A. Diabetic retinopathy. B. Hypertensive retinopathy. C. Age-related macular degeneration. D. Retinal vein occlusion. Answer: A. Diabetic retinopathy. Explanation: this patient's history of diabetes and findings on fundoscopy, including cotton wool spots, microaneurysms, and hard exudates, are characteristic of diabetic retinopathy. Diabetic retinopathy is a common complication of long-standing diabetes, and it can present with blurred vision and changes in visual acuity. Hypertensive retinopathy typically presents with arterial and hemorrhages and retinal edema, but does not commonly cause cotton wool spots or microaneurysms. Age-related macular degeneration typically affects central vision and causes difficulty reading, but it does not present with the retinal findings seen in this patient. Retinal vein occlusion may cause sudden onset visual changes, but is not typically associated with these retinal findings. Question 30. A 55-year-old male with a history of hypertension, smoking, and hyperlipidemia presents with a 1-week history of progressive leg swelling, pain, and redness in his left lower leg. He denies any trauma. On examination, his left calf is swollen, warm to touch, and tender. There is a positive Homan sign. What is the most likely diagnosis? A. Cellulitis. B. Deep vein thrombus DVT. C. Lymphedema. D. Popliteal cyst. Answer: B. Deep vein thrombosis DVT. Explanation: this patient's presentation of progressive leg swelling, pain, redness, and positive Homan sign is most suggestive of deep vein thrombosis. V is condition where blood clot forms in deep vein, usually in the lower extremities, and can present with leg swelling, warmth, and tenderness. The presence of positive Homan sign, pain with dorsiflexion of the foot, further supports the diagnosis. Cellulitis could present with similar symptoms, but typically involves an area of erythema and warmth with more localized appearance and no significant swelling. Lymphedema is typically chronic and present. Gradual swelling and popliteal cyst usually causes swelling behind the knee rather than the entire calf.